Okay, hello and welcome everyone. Thank you so much for joining us for the kickoff of our global webinar series, Exploring Multiple Pathways of Recovery. Whether it's morning, afternoon, or evening where you are, your presence here matters and you are very welcome. My name is Patrick Miller and I am a person in long-term recovery and I am honored to be moderating today's events. I am an IT specialist at Faces and Voices and I also straddle the line between programming, so it's genuinely a pleasure to be here. Now, this series is proudly hosted by the Colombo Plan, the International Society for Substance Use Professionals, or ISSUP, Faces and Voices of Recovery, and the Global Recovery Network, organizations working together to strengthen recovery systems worldwide. Just a quick word regarding this International Society of Substance Use Professionals. ISSUP is a membership organization for the global substance use workforce, with over 35,000 members worldwide. It is an international network that unites, connects, and shares knowledge across the substance use prevention, harm reduction, treatment, and recovery support workforce. Its global mission is to make the work of members as impactful, accessible, and effective as possible. They do this by making it easier to discover and share evidence-based knowledge, best practices, training, and networking opportunities. So if you haven't done so already, please head over to the ISSUP website, issup.net, where you will find information on how to sign up for free membership. The website has a wealth of information and publications for you to enjoy, and you can also watch recordings of past webinars and see future event listings. And I'd also personally like to thank the ISSUP staff for providing technical support for this event. Now, this event is the first in a 6-part series taking place every other Tuesday, concluding on September 30th, which is International Recovery Day. Each phase of the series focuses on building knowledge and capacity across 3 areas. 1, core foundations for recovery, 2, advocacy 101, and 3, leadership development. Today's session launches our foundation phase with a focus on honoring the many pathways to recovery shaped by culture, context, and lived experience. And before we dive in, I just wanted to give a quick heads up regarding some of the housekeeping for today. So today's session is being broadcasted in English, but interpretation in Spanish is available. Please check the link in the chat to access any of the Spanish interpretation resources that we have. Additionally, this session will be recorded, and at the end of the session, you'll receive slides, videos, and resources via email after the session. Additionally, if you have any questions regarding the certificate of completion, that information will also be put in the chat to be shared. In the event that during the conversation that we're having you have any questions, please feel free to enter any of the questions in the Q&A box to submit these questions, and at the end of the conversation, we'll have a Q&A session where we'll be able to speak and ask questions and answer them. Now, with the housekeeping out of the way, it is my genuine pleasure to introduce our featured speaker, Dr. Hannah Hernandez. Dr. Hernandez is a nationally recognized trainer, policy advisor, and advocate who brings more than 30 years of experience in prevention, treatment, recovery support, and systems change. He's a senior consultant to the Massachusetts Department of Public Health and is himself a person in long-term recovery. His work is rooted in equity, cultural humility, and the belief that recovery is a human right. Today, he'll be guiding us through a comprehensive look at how diverse recovery pathways can be recognized, supported, and integrated into recovery ecosystems around the globe. Dr. Hernandez, thank you so much for being with us today, and please, the floor is yours.
Thank you, Patrick, and to the ISSUP folks in the background who are providing the support. Thank you. Welcome, everybody. It is a little after 10 a.m. here on the East Coast of the U.S., and I'm excited to be here. Today, we're going to be exploring the multiple pathways of recovery. I want to just let you know a little bit more about myself. Whenever I go to training, I want to know a little bit more about the presenters. So, I've worked in the field for 37 and a half years, and I've worked in inpatient settings, outpatient settings. For the duration of my career, I've been in not-for-profit settings. And currently, I am Chief of Public Health at a local community-based organization called New North. I am also a consultant on a number of fairly funded initiatives in the U.S., and I worked in every single state except the state of Alaska and in multiple countries all over the world. I was introduced as Dr. Hernandez, and yes, I earned a PhD Uh, I'm a certified prevention specialist. I'm certified and licensed as an addictions counselor. And I also have what is called a GED in the United States, which is the equivalent to a high school diploma. And I earned that in prison. And it was more difficult to earn a GED in prison than a PhD out here. As was mentioned, I am a person in long-term recovery. What that means for me is that I haven't used a drug, including alcohol, for the last 38 and a half years. That enables me to be a productive member of my familia, my community, and to be here present with you today. So we're going to get straight into it. That's a little bit more about me. In terms of a little bit of housekeeping here, there's going to be an evaluation of this. Hopefully, all of you will complete it. There will be a certificate of completion. Um, going to ask that you participate. So hopefully this will be an enjoyable experience. Um, please have your cameras on whenever possible and participate through the chat, through the questions feature, and we will come to questions a little bit later on. Um, in terms of safety agreements, we ask the following, that you come at this with an open mind, that you demonstrate respect even in areas that you might disagree with folk, um, that you encourage yourself to participate as well as others. The ouch rule is sort of, I've been impacted by what you said. You can, call out the ouch and explain why, and we'll go from there. The stretch rule is basically if you talk a lot, to push to stretch backwards and not talk as much. And conversely, if you don't talk a lot, to stretch in the other direction and say a few things. Um, we're going to hold people's confidentiality here. Already, people are sharing personal information, and we want to hold confidentiality. And if there's anything else that you would like to add in terms of safety agreements, please put those in the chat moving forward. And again, we want to make sure that people are enjoying the learning process, the presentation, that sort of thing. If there are things that make you feel a little bit uncomfortable, that's okay. It's part of the learning process. Um, so this training will teach all of us to develop a definition of recovery, to describe the barriers of recovery, to recognize the difference between clinical pathways, non-clinical pathways, and self-management pathways, and there are quite a few there, to explain diverse ways that individuals can get into and maintain recovery, including self-management, moderation, and harm reduction. All of those things are central and important to recovery processes. So we come into this first section. How do we define recovery? How to define it, right? And there's many different definitions, but we want to give you some here that are critical for the conversation. The Betty Ford Center consensus panel uh, defines recovery from substance use as a voluntary, maintained lifestyle characterized by sobriety, personal health, and citizenship. Notice the emphasis on voluntary. In many spaces and places, we try to impose our views, personal and otherwise, views on recovery, and to say to people, this is what recovery is. Um, and so recovery is also about self-determination and choice. And that's why this voluntary language there. When we look at what SAMHSA, the Substance Abuse and Mental Health Services Administration, and their working definition, and SAMHSA is an office within the U.S. federal government. They define it as a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. Recovery signals a dramatic shift in the expectation for positive outcomes for individuals who experience mental health and substance use conditions, or the covering of the two. right? Self-directed life, striving to reach their full potential. There are four domains that SAMHSA talks about as it relates to recovery. That is health, home, uh, community, and purpose. Those four dimensions. So have those in mind as well, moving forward. And you notice from the SAMHSA definition that they don't make any mention of substances, right? Some people have noticed this in the past and said, "Oh, it's really interesting that they don't mention substances at all." And some people have said, "Well, this applies to almost anybody." Uh, yeah, depending on how we see it, right? Um, uh, so how do we define recovery, right? How do we define recovery in terms of faces and voices? Uh, any positive change. So anything um, that is positive, that has the ability to transform people and their families, because let's be mindful, recovery doesn't happen in a vacuum. Recovery happens within the individual, the family, the community, and society in general. So anything that transforms the environment, feelings, right, physical piece, the outlook, perspective, looking outward, and the needs. Um, that for us um, contributes to the definition of recovery. So here's a question for the chat. And I invite you to put some things in the chat. I'm going to slow it down here just a little bit to get some of your reactions. How do you define recovery? What does recovery mean to you? And is there anything that you would change from the Betty Ford Center Consensus Panel definition? Um, so you can respond to one of these, all of these, however you want in the chat. Just know that I am also monitoring the chat. And so I would like to see what you think of when you think about recovery and the definition. I'm going to give you a few seconds to respond to that. Hopefully, some of you are writing into the chat. Again, I am monitoring the chat and encouraging you to share what you think, how you define recovery. So I'm going to move us forward in the interest of time. And I'm sure that you're thinking about how you define recovery. There are many other definitions here. Uh, and when we ask people at the individual level, which is what I like to do, I don't like to define definitions for people that I'm working with. I like to ask, so how do you define recovery? I would also be remiss if I don't mention the fact that some people don't identify with the term recovery at all. And for me, that's fine. If the person doesn't identify with the term recovery and they call it something different, some people call it wellness. I know I've worked with some folks from the faith community, and some of those folks have said, "I'm not in recovery. God lifted the obsession to use. I no longer have that obsession, and I don't need to define with that piece that you call recovery." Some people in natural recovery, they say, "Well, something that has been defined as natural recovery, they go like, just stop using substances. I don't go to groups, I don't go to meetings, I don't do any of that, and I certainly don't talk about myself as being in recovery." My response to all of that is great. How's that working for you, and how can I help? In other words, I'm not interested in imposing definitions of recovery on people, but I do ask, how do you define it, if you do define it, and then we move from there. There are changing perspectives of issues related to recovery, right? And so there are the public perceptions of recovery. Um, so what does that look like in terms of the short term? Acute treatment, institutional settings, and then standardized care. We'll be talking about those moving forward here. And then what recovery should be. So long-term treatment for chronic condition, right? We're talking about this more and more and more and more. Individualized services. So how do we individualize services to meet the needs of the individual, as opposed to painting with a broad brush and thinking that everybody needs the same. We all have similarities and things that we need, but not everybody needs the same. And then community based. Uh, Many times we take people out of their homes, out of their communities, we treat them over here, and then we place them back in these environments that haven't been addressed. And then when people have a recurrence, a return to use, or signs and symptoms of their disease or diseases, we blame them for that. And so what we're looking at is how do we couch recovery within community-based settings? And then it has to be based on self-determination choice, right? That people get to choose when they're in recovery. They get to say when they're in recovery. They get to identify what recovery or wellness means to them or what it doesn't mean to them. And we as providers need to be okay with that. Historically, we haven't. Many people have been treated badly because we don't agree with the way that they're doing things. And at the end of the day, I'm reminded of William White and what William White says about recovery. Um, Recovery can be initiated in treatment, but recovery happens in community, right? In community. And for me, that is huge, um, because community is where we live and where we practice, right? Now, we all know that there are barriers that are associated with recovery, with people accessing, gaining, and maintaining recovery over time. And so when we talk about what is a barrier, it's anything that makes it harder for the individual to access resources, material, recovery capital, whatever those things are, right? Some examples of barriers, we put them into different buckets. So there's the structural barriers, right? When we look at infrastructure, when we look at bus routes, again, recovery happens in community. And if it's more difficult for people to access it because of infrastructure issues or bus routes, it becomes more difficult. There are institutional barriers, requirement for an ID. Um, you maintain sobriety to access housing and or other resources. There are these preconditions that historically we put in front of people. If you want this, you need to do all of these other things, putting people through hoops. And many of those hoops are not necessary, right? And then there are personal barriers that include biases, and how we treat people, how we view people, but also how people view themselves who have substance use conditions or mental health challenges. And then our own barriers can be one of the biggest hindrances to issues of recovery. I know that I went from prison to treatment, not because I wanted treatment, but because I wanted to get out of prison. And so when I arrived in treatment, I was in pre-contemplation, had no interest in issues of recovery or stopping to use drugs. And so that barrier was mine because I didn't understand substance use as a condition, as a disease. I was not interested in engaging in treatment. That doesn't mean that I didn't engage. That just means that it was more difficult for me because of those barriers. And so we all other barriers, obviously, right? We all have a responsibility to understand what those barriers are to the individuals that we're working with and then work towards eliminating or reducing those barriers as much as possible. Why do I say eliminating and reducing? Because in many cases, I don't have control over the policies that exist within organizations that make it more difficult for people to access recovery or recovery resources. The biggest barrier is stigma. Now, I want to say this historically in our we have blamed people for conditions that they did not create. We have said people, this is what we understand as sobriety or recovery. We place labels on those. This is what your problem is. This is what you need to do. This is how you do it. And that's that. And then when people don't have success or they have a recurrence or return to use or signs and symptoms of their disease, we blame them and we say, it is you who are problematic. It is you who are in denial. It is you who don't want to take personal responsibility for yourself. And we forget that stigma um, is also driven by policies. It is driven by structures that allow for some people to get in or pushing some people out. And so we have a number of barriers that are connected to structures. The main response, at least here in the US, over the decades, have been a war on drugs that some of us have called it a war on people. It makes it more difficult. And we send people to prisons and jails and incarcerate people as opposed to providing places and spaces where people can get better. And so stigma is driven by knowledge, attitudes, beliefs, and then behaviors. But it's also driven by policy structures, policies in terms of laws, but policies within organizations, policies and procedures, again, that make it more difficult to gain access to what we're talking about. Um, in terms of stigma, it's an attribute, it's a behavior or condition, as I was talking about earlier, that is socially discrediting, right? When we look at the research studies, participants are about two people actively using drugs and alcohol. The person referred to as a substance abuser versus the person who's referred to having a substance use disorder, right? And I'm going to go through these with you very quickly. It's less likely to benefit from treatment when we refer to someone as a substance abuser. It's more likely to benefit from punishment. That's that criminal injustice approach. More likely to be socially threatening. More likely to be blamed for their substance related difficulties and less likely that their problem was as a result of innate dysfunction over which they had no control. They were more able to control their substance without help. So you see that our language, attitudes, beliefs, and behaviors has an impact. And this is what research says. I work with people all the time and I talk about issues of language. Let us stop pathologizing people, calling people addicts and frequent flyers and substance abusers and in denial, schizophrenics and bipolars. And that language is used a great deal in our field to describe people. And so that language is also internalized by the people that we're working with. And some people have said to me, so what you're trying to do is to be the PC police around language. And I say, no, that's not it. The reality is that if I use language that's stigmatizing, that makes it more difficult to for people to get better, and I know that based on research, I should stop using language because it doesn't help anybody. And I know that changing language is difficult to do, but it's not impossible. It's not impossible. We should be thinking about how we use person first language, right, as the solution to this pathologizing and stigmatizing language. So I don't talk about when I introduced myself to you, I said I'm a person in long term recovery. And I said, what that means for me is that I haven't used drugs in this amount of time. What that enables me to do is X, Y, and Z. Why did I not introduce myself as an addict? Because I'm not an addict. I've never been that. Right? Um, and so we should model first person language. This is a person with a substance use disorder or a substance use condition or a mental health challenge. This is a person experiencing homelessness as opposed to talking about homeless people. This is a person, right? First and first language. I don't call myself a felon. I am not that. I am not an ex-convict. I am none of those things, right? Do I have a a past and touch with the criminal justice system? Of course I do. But that's different from getting up in front of people and say, I'm a convicted felon or you know, uh, I'm a convict and those sorts of things. They never help anybody to do anything positive. They just make it more difficult for people. Now, I know people who are in recovery and they refer to themselves in that terminology. Again, I don't beat people up. I just use myself as the power of example, and I try to explain why I don't use that language. And people can do what they do as a result of that. Now, let's move to pathways of recovery, right? Um, there are three pathways. We're talking about clinical, non-clinical, and self-management. We're going to get a little bit deeper into these here. So begin with the clinical pathways of recovery, beginning with those. There are four levels. When we think about level one, we're talking about outpatient, right? Level two is intensive outpatient and partial hospitalization. Number three is clinically managed high to low residential inpatient services. And then number four is medically managed intensive inpatient services. And so when I look at the different levels of care, for me, it's important to assess people and not to think that just because I work in a place that has a residential treatment program that everyone who comes through meets the program that I run. Or if I have an outpatient program, that everybody needs outpatient. If we're going to be ethical and realistic and meet people's needs, we need to do an assessment to see what level of care is appropriate for the individual. Now, these are clinical pathways, right? So there needs to be people with right credentials that can do the proper assessment, that then we can provide options in front of people so that they can make a choice in terms of what they're interested in doing. Notice that I said we do an assessment, we put options in front of people, and they get to choose. As opposed to the first question walking through the door is, do you have health insurance? Because we want to fit you into our treatment program. Um, different levels of cares again requires assessment and then um, going into uh, what that looks like for people by way of referrals. In terms of behavioral interventions, there are quite a few. So when we look at acceptance and commitment therapy, or ACT, that is a form of interacting with people. Cognitive behavioral therapy have been used for very long, CBT, and all of this requires that we've been trained in these disciplines to be able to implement them. Family therapy, which I am a fan of because historically, and even to this day, in many spaces and places, we work with the individual. Yet we understand that substance use disorders impacts the entire family and it impacts communities. So how do we engage family members into the therapy process, right? I know that that was really important for my family because they didn't know that substance use was a disorder. They thought that it was just a lack of willpower, right? To no fault of their own, but there are many families who don't understand these things, and they're deeply impacted by substance use. Behavioral couples therapy, motivational interviewing is being used all over the world, all over the country here, and with very good results, right? Because it's a non-punitive approach to engaging people in their own process of wellness and getting better. Um, what is labeled here relapse prevention, we're moving away from that language and talking about recurrence, and that we should be doing recurrence prevention from the first moment that we come in contact with people. Historically, what we have done is we have left this thing called relapse all the way to the end. No, part of being in recovery is understanding triggers, understanding what we can do to avoid certain things, right? To prevent um, a recurrence from happening, to surround ourselves with family, community, peers of people who can support us because they know what we're going through. Contingency management, right? This is this process of providing people with rewards for doing the right thing, and it's been evaluated to be effective. And then community reinforcement, coming back to this notion of recovery doesn't happen in a vacuum. It happens within community. So how does community reinforce recovery processes, wellness processes of getting better and healthier. Um, then there is what many call MAT, medication assisted treatment. Others call it MAR, medication assisted recovery, MOUD, right? There's many ways in which people are calling this. That said, only 20% of people with a opioid use disorder receive any MAT or medication assisted treatment, right? Only 20%. Only 33% of people in treatment receive MAT. Of those who are in treatment, only 33%. MAT is the standard of care for opioid use. Now, remember this, there are multiple pathways of recovery. So just because it's the standard of care, it doesn't mean that medication is good for everybody. Some people are not going to use medication. It's their choice to decide if this is what we want or not. Now, having said that, we have a lot of data that speaks to the effectiveness of medication for treating opioid use disorder. Um, there are many medications here. These forgiveness on the slide because it's difficult to read, but I'm hoping that you're going to get copies of the slides. And so when we see the medications that are available for opioid use disorder, we see that there's injectable naltrexone, there's buke, there's naloxone, there's methadone. There are all of those medications that have been proven to work with folk, right? So if you're one of those people who works within the space and you understand medications and all of that, great for you. If you're, I know a lot of people who don't understand medications and they want more. There's opportunities for more in-depth training on what these medications are, what they do, the effects, the route of administration for whom, the side effects, all of that stuff is available with additional training. Just because you don't understand something is not the reason for saying, well, that doesn't work. Because connecting this back to stigma, many people in our field and many people in recovery as well think that if someone is on a medication, that's not really recovery. They just switch from one drug to the next. And before Vivitrol and Suboxone and Buke and all these medications came out, we had methadone for a very long time. Methadone is one of the most stigmatized medications in our field. And people would say, oh, they're really not in recovery, or they're not really working a program because they're on medication. They shifted from one thing to the next. Why do I say that here? Is because we need to check our biases around these things. People who are doing really well on medication, and the research is out there to prove, right? Um, so where do people go to receive medication for an opioid use disorder, right? There is office-based or OBOT, office-based opioid treatment, and then there's opioid treatment programs. And now, when you look at least here in the US, in terms of where these programs are located, methadone clinics are all over communities. And because of stigma, we place them in the most undesirable places in town. We made people line up outside with security and police officers, and many of us have said that's really dehumanizing. It produces stigma, all of that. Many of the medication-assisted treatment programs that we have now are co-housed or located within federally qualified health centers, in hospitals, in primary care settings, in different settings that are more medical settings with the proper recovery supports surrounding them. So that's an attempt to break away from the stigmatizing portion of what we have done in the past. Um, there are medications for folks with alcohol use disorder, and we see them there, naltrexone, acamprosate, Defersium. There's one that now Primatate, it's not FDA approved. Um, and gabapentin is not FDA as of yet. Those are medications that exist. for people with alcohol use disorder. So for those folks who are working with people who have challenges with alcohol, there's referrals to be done in relationship to that. And there's obviously, we have had treatments for nicotine and for a very long time. Many people don't talk about this as we did in the 90s when all of the policies were coming out. But we have nicotine replacement therapies or NRTs. We have varicillin and bupropion. And again, these have been used by people all over the world, here in the US, with very good results. And it has been said that, stopping to use nicotine via smoking and other products is one of the most difficult things to do, but it is possible. I used to smoke when I got into recovery. I didn't use any medication, but I was able to stop with a lot of supports from my peers in the treatment facility, which I was in. I'm going to shift here and talk about the non-clinical pathways of recovery, the non-clinical pathways. There are holistic recovery options, right? And so alternative therapies, when we think about alternative therapies, we're talking about meditation and yoga and acupuncture, those things, and acupuncture has been around for thousands of years. I'm old enough to remember when we used acupuncture at detox centers, right, with really, really good results. There are creative therapies that people use over the world, animal assisted therapies, from dogs to horses to birds to like many different ways of utilizing animals in therapy. And then there are wilderness therapies, right? People go out into to commune with nature, to commune with their fellow travelers, to do many, many different things. I was in Nicaragua a couple of years ago, and young people there were utilizing exercise in recovery. And they invited me to do a sled down a dormant volcano. And then we did some swimming and surfing at the end of the day. And while talking about recovery processes. And that was an amazing experience for me because I had never done that. But there are movements all over the world and how to support this stuff, right? When we look at mutual aid, this is what people call self-help. There's no such thing as help, self-help. Mutual aid, it's in the mutuality, right? So we're talking about your Alcoholics Anonymous, Narcotics Anonymous, Women for Sobriety, Life Ring, Smart Recovery, SOS Recovery. All of these things are mutual aids, been proven to be effective, have helped millions of people all over the world. Um, Now, they don't get the same recognition as other ways of recovery in some circles because we don't have research that proves that they work. But here's what we do have. At the very least in the US, there are 23 million people who identify as being in recovery from substance use. There's an additional 44 million people who identify as being in recovery from a mental health condition. And that all of those people did it in many, many, many different ways. I'll give you an example of this. You can go to 12 step, you can go to NA, AA, or GA, Gamblers Anonymous, and you can be there and be in recovery and doing the right thing and do it differently from someone who's in the same fellowship with you, right? And for me, it's not about doing it the same, it's doing it in the way that is best for you, right? And again, my questions are always to people, how's that working for you and how can I help? Not to lead with, oh, you're doing it wrong and this is what you need to do, is to better understand that. There are recovery residents all over the world and here in the US, and we have Oxford House as a model. Um, and they're, I think, like in 44 states across the country. In the state I'm in, Massachusetts, they're here as well. And there's the National Alliance of Recovery Residents, or NAR. And then there are a series of recovery homes that are owned by individuals all over the country, all over the world. Um, and people either we got prisons and jails or communities, or they are a step down from an intensive inpatient facility around treatment, and they're managed by the people who live there. They're sustained by the people who live there. They can also bring in groups, your rational recovery, your 12-step groups, and all of that stuff within those spaces and places, and they've been proven to be very effective. Um, there's something that we call education-based recovery services, collegiate, um, and these are created um, to provide access to recovery supports on college campuses, right? There's social and educational support. There are supports that includes over housing, mutual aid meetings, counseling, and social events. So you see that there's a lot of things converging here together to help people. And then there are recovery high schools here in the state where I live. There's quite a few recovery high schools, right? I wish I had access to one of those when I was in high school or when I was headed to high school, because I didn't drop out of high school. I was pushed out of middle school. So there are instructional focus with normal high school curriculum, right? The difference there is that we see that the young people enrolled are young people who identify in this process that we call recovery. It integrates the academic instruction with social emotional skills acquisition and recovery supports. There are 42 high schools in the United States with an additional 5 schools in development. I think here in Massachusetts, we have 3 of them, and I've been fortunate to be able to tour them, do some training for their staff and that sort of thing. And it's amazing to hear the stories of young people who are in recovery within these high schools and what that has meant to them. They report the absence of peer pressure to use substances and the to do a lot of other stuff that comes with being an adolescent. And what they report is an increase in participation in community activities, in recovery supports, in groups, and all of that good stuff that is available through those schools. Then there are the recovery community organizations or recovery support centers. Here in Massachusetts, we have 39 recovery support centers that are funded by the state and an additional 20 plus that are funded by individual contributions. They're community based and they provide support in the community. They're typically run by not-for-profit organizations with 501c3s, even though I know some that are privately owned, but they provide services to everybody. They provide connection to local recovery supports. This is the community aspect of what I was talking about earlier, as opposed to taking people out of their environment, treating them over here, putting them back in. They're generally peer operated, right? All of the ones that I told you about here in Massachusetts, all staff there, including the directors and everybody else, are all people in recovery. They intend to help improve access to recovery resources, day-to-day challenges to build individuals' recovery capital. And when we talk about recovery capital, we're talking about internal recovery capital, right? Which is my ability to say yes, my ability to advocate, my ability to, right? And so within recovery support centers, they work with people to develop, further hone those abilities. And then external recovery capital, housing, healthcare, employment, income, all of those good things that support recovery. And then the services may include recovery meetings, peer recovery coaching, connection to local services, job training, and other recovery resources. And so communities run them, right? Recovery communities run them, and they get to decide what they bring in. And the peer recovery coaching aspect of this has exploded all over the world and here in the US. And it helps people connect with a coach that's going to help you identify your goals, your objectives, and going to be a cheerleader to support people in those recovery processes. There are links after each and every one of these slides that you can um, go to learn more. Employment-based recovery services. So when we talk about that, we're talking about employment and workforce development training. Um, the recovery coach model is a perfect example of that. how we've taken people with lived and living experience, trained them through recovery coaching processes, and then they get a job in our field. Many of those peers are working in recovery centers, in clinical settings, in emergency departments. They are working in primary care, in federally qualified health centers. And now we have a movement of peers and recovery coaches working behind the wall to help with reentry before they come out. 4 to 6 months people come out, these recovery coaches are reaching in behind the wall. I have two programs here that help Black and African American and Latina women and men 6 months before they get out in that transition process. And this is all based on the employment and workforce training development to help people to understand and do that. Employee assistance programs, so your EAPs, right, are designed to do this by way of employment. Many people who work in different settings, they have access to EAP, and that it's their right to access it. Um, and that EAP has people who specialize in substance use in most places. And then recovery friendly hiring policies. This is something that Faces and Voices and other organizations help organizations think about how if you're going to hire people with lived and living experience, then your policies and procedures need to reflect that reality, right? How do you supervise people who are in recovery? How do you provide for mental health days, for vacation days? How do you understand when people are having challenges with their recovery? How do you understand that it's illegal to fire people because they had a recurrence? That we must engage with people and treat them to options that they can go and get their substance use issues under control and to the place of employment. And that as we think about holidays and things like that, organizations are having parties and celebrations. Hired people who are in recovery to your staff. Are you really going to have an open bar at your Christmas party? Or are you really going to things that raise funds? So recovery friendly work environment includes the review of policies and procedures. And then organizations that are started by people in recovery to employ others in recovery. We have plenty of those all over the country with recovery community organizations and all over the world, right? They understand the value of hiring people in recovery, and they also understand the value of collaborating with organizations who are not set up that way, but there's value in collaboration and cooperation. There's faith-based in recovery. I talked a little bit about faith earlier, right? There's Celebrate Recovery, there's the Jewish Board, there's GACS, there's MI, uh, there is Recovery Dharma. So there's many different, I know many churches, mosques, and synagogues and harm reduction programs within them, outreach programs. I know that people from the faith community, for decades and decades and decades, they have been doing prison ministries, right? Going behind the wall, working with people on mentorship programs, all of that before they come out. Um, and so these are effective, again, for people who that's their pathway of choosing. And that's the emphasis here. All of these pathways are effective, but people need to buy into and choose that that's what they want. It can't be an imposition on them. There are culturally specific ones, and this is right down my alley because I live in this space of, we are diverse in the world as it relates to cultures. And so I am from Puerto Rico, and the treatment facility that I went to was an all male treatment facility for Latino males, very specifically, where the food, the language, the culture, the cultural elements were all reflected there. I did well because I saw myself reflected within the structure, within the staff, within the language, within everything there, right? And so I developed here by, for, and with Native Americans. The outcry in the barrio, also developed by a group of people, right, from the Christian faith, um, as it relates to communities. And the National Compadres Network that I happen to know, respect, and do some work with them here in the US. These are culturally specific. Again, they take the cultural elements of the communities and they do that. Ubuntu. I have a friend in Pennsylvania, and they use the African principles of Ubuntu to develop recovery supports for people of African descent with really, really, really good outcomes, right? So the cultural elements become extremely important in engaging, treating, sustaining recovery all over the world and here in the US. Then there are the self-management pathways of recovery. Self-management pathways of recovery. Think about this natural recovery. Of the 9.1% individuals in the US who describe their alcohol or drug usage as a problem, of that 9%, only 50% seek external assistance. Of all people, right, who describe their alcohol or substance use as a problem, only 50% seek external assistance, which that that other 50% need to look at other ways of getting better. Just because you didn't seek um, external assistance doesn't mean that you don't get better. Many people do. Now, some people do need the external assistance, right? And so, what do we focus on? We focus on harm reduction. And so, before I go deeper into this, I want to say the following. Many of you have been trained in stages of change by Prochaska and Di Clemente, right? Prochaska Clemente. And so they talk about pre-contemplation, contemplation, preparation, action, and maintenance. Many of the people that we come in contact with are in pre-contemplation or contemplation. They're in preparation or action, but if we don't do a proper assessment, we won't learn where they're at. And pre-contemplation is not interested in doing any of that. As I told you before, I went from prison to treatment, not because I wanted treatment, but because I wanted to get out of it. And many people are coerced into treatment by both the courts, family, conditions on the ground. And so if I understand that there are people who are in pre-contemplation and contemplation, in other words, they're not ready to stop, they're not ready to, they're not interested in stopping. Well, for me, it's important to understand that dead people don't recover and that I need to meet people truly where they're at, psychologically, physically, spiritually, emotionally, in all those areas. So, what is harm reduction? It is a broad pathway or a group of various pathways that prioritize managing continued using or the cessation of using altogether by educating and empowering people and communities to manage their risk associated with substance usage. Right. So there's a lot of stigma that is associated um, with harm reduction. So, what are some of the tools? So, naloxone or Narcan, right? Again, dead people recover. Some people have said, "Oh, these things just enable people to continue to use." Listen, I know people who have overdosed 5, 10, 15, 20 times, and now they're in recovery. Imagine if we would have said, we shouldn't deal with them because they're in denial and what they want to do is using. Those people would be dead. They wouldn't be alive, right? Syringe and needle access. I'm not interested in people getting infected with HIV or hepatitis C or other conditions, right? That create infections of the blood and everything else. So providing those things become important. Cookers, tourniquets, ties, cotton, citric acid, right? Safer use strategies, wound care, treatment assistance, and linkage to care. These are tools within our tool belt to help people. Now, some people will say, no, I'm not interested in helping people. So refer them to someone who understands that and that can do it. Do not get in the way. Do not get in the way. One of the most controversial things right now in harm reduction is what has been called safe consumption sites, which are now relabeled as overdose prevention centers or OPCs. And I ask each and every one of you in this seminar, How many of you have ever been into a legal safe consumption site? Into a legal safe consumption site, right? Think about that question. You just answered it for yourself. I am guessing that the majority of you have said, never been into one of those. Then I'm going to ask you the question in a different way. How many of you have been into a bar? Or how many of you have been into a party where alcohol is being um, distributed legally? Those are safe consumption sites. They've been around for decades. Our attitudes, beliefs, and behaviors and stigma is related to people who use illicit drugs because we many times have been taught to believe in punishment as opposed to saving people's lives and enabling them to get better. I work with people who say, I want to go from 3 packs to 10. And I go, great, let's work on that. I work with people who say, I don't want to stop. I don't want anything to do with that. I want to shoot up. And I say, I have syringes. Okay, give me one of those. That's where I start. I work with people who say, I want none of that. And I say, are you hungry? Yeah, I'm hungry. So let's eat. It's a place start the conversation and the engagement process. It's not a place for me to come with my moral high ground to tell people what to do, when to do it, how to do it. That has never worked. So if you don't know about harm reduction, please get more training on harm reduction and understand harm reduction is saving lives of millions of people. I have an outreach team here, and we do harm reduction for people that we come in contact with. This is what harm reduction is not. It's not an anything goes. People who don't understand this, they come up with stuff that doesn't make a lot of sense. Helping a person to return to use, it's not that either. If a person chooses to return to use, is to give them the tools to use safely. They don't die alone in a room because they're using by themselves, or they're getting infected with HIV or hepatitis C because we have stigmatized people and not allow them to get the tools that they need, right? Condoning or endorsing or encouraging drug use or other risky behaviors, that is not what we do. Removing professional or personal boundaries, that is not what we do either, right? The research is clear. If you feel a certain type of way, then I would say read a little bit of the research. Reading the research and the outcomes will tell you that these stereotypes that we have are based on that stereotypes and bad information that have been distributed, repeated, and sustained over time. And I speak a great deal to the folks who are in recovery. Now, there was a point in time in early recovery that I thought that harm was condoning drug use, but I had good mentors and I had an attitude of learning. And so I changed my mind. And now I support harm reduction. And I've been supporting harm reduction for over 25 years. There's moderation-based pathways, right? Self-guided change is one of the most common forms of long-term maintained health behavior change. Moderate or controlled drinking is a harm reduction approach that does not prioritize cessation of usage as part of the recovery pathway. And again, if you haven't met people who have used these pathways, I recommend that you seek out groups or people and to learn more and to suspend judgment, because I don't believe that there's anything as non-judgmental. We all judge, but I can suspend judgment with the goal of learning, right? And moderation management has been around for a long time and it helps people, and it has, again, for the people that's what they choose. There's going to be some people who say, I'm not interested in stopping my alcohol use. Okay, that's fine. So what are you interested in doing? I'm interested in managing it or controlling it. So there are pathways that help. Here, you see that the University of Michigan has an alcohol management program, right? For anyone who wants to eliminate the negative consequences of their drinking and improve their health and well-being. The effectiveness here, right, has helped people moderate or stop drinking altogether, reducing drinking by approximately 65%. You see, this is what I'm talking about by way of paying attention to the actual research and data as opposed to saying, well, that's never going to work because I tried it and it didn't work for me. It's not about you. It's about the people who are in front of us, right? Accessibility sessions can be in person or by phone. If you have been wondering, do I drink too much? Are some of the questions that we have people, right? Would my life get better if I drank less? Is my drinking considered risky drinking? My drinking affecting my health? How much is too much, right? These things actually help a great deal. Okay. I am moving forward. I am looking at time. So I'm going to go through some of these rather quickly so that we have enough time for questions here. How many people may eventually abstain completely, but 50 years of research evidence clearly indicates that most drinkers moderate their drinking behavior, right? Data from a study by Lopez Quintero and colleagues in 2011 indicate that 5 years after becoming dependent on cocaine, 50% of cocaine users have quit. More than two-thirds of the total remission occurs within 10 years after dependence, with time to remission verifying based on ethnic group. And then when we look at these things as it relates to opioids and heroin, some research here, right? Many heroin users quit on their own. Many do. Recovery, according to Blanco and colleagues in 2013, 96% of people with a history of misusing prescription medications, including opioids, eventually stopped. 50% has stopped within 4 to 5 years after becoming dependent. Again, it's important to understand what the research is saying here. And then there's recovery utilizing psychedelics. And you see they've been used in the treatment of PTSD and other conditions here, OCD, ED, and DE. And so we see cannabis, LSD, and the other ketamine and the other um, uh, substances that have been used to help people, right? And MAPS, they envision a world where psychedelics and marijuana is safely and legally available for beneficial uses, and where research is governed by rigorous scientific evaluation of risks and benefits. And so there are some states considering and changing policies as it relates to psychedelics, which is promising for many different reasons. So, what happened here? Um, the data and psychedelics, I won't review those in more detail, but this is an opportunity for questions. So thank you for chiming in, listening. I'm going to open it up for questions, comments, anything you might have there.
Well, thank you so much, Doctor. That was an incredibly thoughtful and powerful presentation. So I'm glad that we all had the opportunity to ask some questions. And we have been getting some streaming in, but for any of our listeners out there, feel free to start putting in any of the questions that you might have for the good doctor, and we'll be able to address them. But I'm going to start a little bit earlier in the conversation. Um, a person named Joran Solberg asked, how significant is the neutral use of language in discussing substance users and the recovery and just generally in the recovery ecosystem?
I think thank you for the question. I think it's extremely important. I think it's central to what we do. Imagine if you go to a place for help and someone is using language that is calling you an abuser, an addict. Imagine if someone is calling you homeless. Imagine if someone is calling you bipolar, schizophrenic, frequent flyer. Those are damaging words that are accusatory. It's not just a word; they have meaning. Now imagine if you walk through the door and somebody says, "Patrick, thank you for coming. You look good. Um, I'm happy to see you. And tell me a little bit about yourself." Um, and when we get into that conversation, then I say to Patrick, I too am a person with a substance use condition. I too am a person who experienced incarceration. I too am a person who slept in the park and experienced homelessness. But you know what, Patrick? We don't have to live that way anymore. And I know that that terminology is hurtful when people called you, you know, those names of homeless and an addict and convict and all of that. But I am here not to treat you that way. I am here to engage and to better understand you so that I can be a better help to you. I am your ally. Where do you want to go? Who do you want to see? You want to see that first person who pointed the finger and called you all of that? Or do you want the person who's trying to humanize you, who is trying to bring you in from those spaces and places where you're treated badly? Our folks have been dehumanized, and this language that we use is dehumanizing language. And I refuse to use that language because I know it was dehumanizing to me. And listen to this clean. Oh, my clean time. So, what's the opposite of clean? The opposite of clean is dirty. I spoke at a conference. I speak at a bunch of conferences, but I'll never forget this one. I spoke at a conference and I was talking about language, and I used the example of clean versus dirty. And when I finished, and people clapped and that sort of thing, this young woman came up to me and she was in line waiting to speak to me after my keynote address. And as she got up, tears were coming down her face. And when she come up to me, she said, "Thank you for saying that. I always believed I was dirty, and I am not dirty. And you are the first person who I heard say that." Listen, my tears came down my face because I said, "Oh, wow." Sometimes we say things and we don't know the power of what we use and what we say. So, for all those reasons, now I gave you the emotional, right, reasons why. But research proves exactly what I'm saying. And I gave you a slide that says when you talk about people as substance abusers, we're more likely to treat them X, Y, and Z. There's research that says that when lay people hear the word addict, they go, "That's Hanel who stole my car. That's Hanel who stole my purse. That's Hanel who sold drugs in the corner." When people hear the term a person in recovery, that is a different part of the brain that's touched with that messaging. I know that that's a long answer to a basic question, but that's not a basic question. It's a complicated issue. Thank you for the question.
Thank you for the answer. And just like as a quick aside, I'm a person in long-term recovery and I was a recovery specialist and I understand the importance of language, but even you talking and answering that question struck me as a person in long-term recovery. So that just really highlights the importance. That was an excellent answer and an excellent question. Thank you.
Thank you, Patrick. Thank you.
And I think, oh yeah, absolutely. And I think in a similar vein, Emily Mora asked, when you are speaking about NA meetings where a person at a meeting introduced themselves as an addict, what are your thoughts on the use of that language in that like specific moment?
Yeah. Emily, thank you for that. Again, and I'm eclectic in terms of my recovery process. I'll go anywhere. If there's something there that's about recovery, I'll sit down and take in what I need to take in because my mentors told me, don't push anything away until you really know what it is because you might be getting something there. So I have a lot of friends who are in 12-step fellowships and they call themselves addicts, and I have my family and other people that I know that they call themselves addicts. I'm not the word police. I don't go correcting people. I'm talking about that here because we are in a training. I don't stop people and say, "Yeah, that's stigmatizing this and that, the other." What I do have is individual conversations with people. And so a lot of people come up to me and say, "Oh, so why don't you call yourself an addict?" And I go like, "Here's the reason why, right?" Um, or there's a conversation about that and they ask me, "So what's your opinion on this?" Because things are changing. Then I will be careful with my words, but I will give an opinion, but I also say, "Here's what my opinion is, but here's what research says. You do with that what you want," right? um, and right now, things are changing because we have 12-step fellowships where people who are on medication assisted are there and they're participating and they're being treated positively. So even within those spaces and places where historically it has been really rigid, there's an opening up. There's an opening up. And that's why our presence is important in those spaces and places. And I've sat in groups where someone gets up and says, "Yeah, I'm an addict," and then the next two people say, "No, I'm in recovery." And they don't say anything else. They just talk about themselves. And I go, oh, wow, somewhere, right? Have been exposed to language that is opening things up for other people, right? And so it lies with that. I was a clinical supervisor at a federally qualified health center up until recently, and there we were using dirty urines and clean urines. And I said, listen, let's not use that. We should talk about positive and negative. We should talk about right? Urine screens and talk about them not in stigmatizing ways. So it's not just within the recovery community; it is within spaces and places that want to help, but they haven't yet been exposed to language that's empowering, that's humanizing, that's all that. And I think that when we talk to people's hearts about what this means, then people go, "Wow, that makes sense." And then let's not beat each other up because there's slips in language. To change language is very difficult. And I know really good people who say substance abuse, and then they catch themselves, oh, I'm sorry that I said that. No need to correct people, right? When I speak, I'm going to try as much as possible to use that person first language and let that land where it lands, right? But if you're working within organizations, your staff meeting, your professional development day, your trainings are an important way of helping people to understand issues of language. So bring someone in who can talk about this, not at people, a conversation with people.
Wow, what an amazing distinction to make too. Like the way that you approached it was externally being validated and internally validating yourself with the use of language. That's a really powerful answer. Thank you. And I think it ties pretty well into our next question. So this is from Raul Ayala. Drug courts participants are required to follow certain terms and conditions as required by law and other program-based requirements, which are often a significant barrier to recovery. How may we more effectively balance these two principles to help participants gain long-term recovery in that context?
So there's a revolution in this as it relates to criminal justice settings, right? And drug courts, veteran courts, mental health courts, and now we're calling them, get this, recovery courts. Get that by way of language, recovery courts. Um, so to come specifically to the type of course that you're talking about, I was in Vermont recently giving a talk at the Vermont conference on substance use and recovery. And guess who was in the audience? Three judges, right? And so my talk always includes issues of language, recovery pathways, the multiple pathways of recovery, all of those things, right? And it always includes choice, self-determination, and I speak so that we are cautious about telling people what to do, when to do it, how to do it. You see how that rolls off my tongue? Because that's the way I talk in many different settings. When I finished my talk, I had lunch. And guess who sat at my table? The three judges. They wanted to talk to me about the multiple pathways of recovery. And one had heard about the multiple pathways, and the other two, they were imposing, like everyone's going to go to 12-step groups, right? And what I was saying is, no, there's multiple pathways. And so it works best when you allow people self-determination and agency because you want them to succeed, right? And so they sat with me and said, well that's really interesting. Can you come to the New England Drug Courts Conference and present on this? Because we need to change things up. Here's what I'm saying. Within drug courts, there are champions and people with a lot of power, and those happen to be the judges. They control that court. It's their court, right? But they're open to conversation. So now we have recovery coaches within that space. We have other professionals within those spaces advocating for people. And so I think it's a coordinated effort to help change the culture of those spaces and places, right? Um, and I have seen the court here is not called the drug court, it's called the recovery court. But that happened as a result of education. And the person who decided to change the name was the judge. because the judge was exposed to the education and it was supported by recovery coaches and people. So, I encourage engagement with these spaces and places, right? The other thing is that most drug courts are white. 85% of the drug courts here are white, 15% people of color. And so, why do I bring that up? Because we need to also talk about the fact that everybody deserves a chance at diversion programs and opportunity, right? Especially folks who historically receive prisons and jails and punitive approaches. Uh, and whenever I've spoken with professionals from those spaces and places, none of them have ever said it doesn't make any sense. They go like, yes, we need to do better. And then they're looking for opportunities to do that. So if you're working in community-based organizations, those drug courts are interested in partnering with community-based organizations. Why? Because they know that they can't be all things to all people. They need, and we need them as much as they need us. So I hope I did your question some justice there by way of the engagement with recovery courts, mental health courts, drug courts, veterans courts, all over the country.
I love the use of recovery court. I mean, personally, my local county has recently adopted that, and I think it's just I love it. And actually, this ties well with the next question on almost an inverse level. How do we deal with misinformation and shaming of substance users from supposedly reputable organizations that impact substance use? Specifically, this question in a small island community, but I'm wondering if there might be like an extrapolation. Like how do we deal with misinformation and shaming?
Listen, there's one of the leading researchers on issues of stigma in the U.S. is out of Columbia University in New York, and I had the pleasure of presenting at Harvard at a conference where he presented as well, and I learned so much from him because he came to the audience and said the following, which is profound, and we've been using this in recovery spaces. He said, you can beat people over the head with percentages and numbers. 20% of this, 30% of that, 30. I did some of that here, right? With research. And I harp on research because I believe in research, right? All of that. But for some people, numbers are not going to change their mind. They're not. And so we need different language for different audiences, for different people. Some people will only hear us if we talk cost benefit analysis. And that comes from the business community. The folks in recovery, you say cost benefit analysis, and they're like, what the hell is that? I don't know anything about that. Hmm? So what did he say? He said, for some people, we need to use research and numbers because they're only going to listen to that. Policymakers are interested in numbers and right and research and all of that. Here's another piece that we are using that policymakers are also paying attention to, and that's storytelling. Our stories have power. Stories are powerful. There's nothing like telling a story that connects people here and here, connects people in both places, right? The question is, how do we tell our story in a way that's compelling and not stigmatizing? How do we tell a story that doesn't include this negative terminology that we're talking about? And there are trainings that help us engage in that. And Faces and Voices of Recovery does that type of training, right? It is training that is humanizing, that reduces this punitive approaches and increases person first language. Again, I'm going to come back to that example. I didn't introduce myself as Hanel the addict. Said, my name is Hanel. I'm a person in long term recovery. This is what it means for me. This is what enables me to do. I need very little room. So that professor from Colombia talked about the fact that the way that we tell our stories has greater impact in society and in community. And you know this because you've been in front of people that captivate you right away. When they start telling a story, you're like, oh, wow, this is really interesting. When you start reading a book and it's story based and you go like, oh, wow, this is it. I want to read more. I want to learn more about this. So if you don't have training, get training. Think about the different audiences, right? The cost benefit analysis, the statistical stuff, right? The numbers and data, and then the storytelling. I try to use a combination of all of it. I'm going to give you a quick example of New York. New York has the first two opioid prevention centers in the country run by my friend Sam Rivera. When they developed the two centers, many people were dead against them. They did this analysis. In New York City, if you call the EMTs because of an opioid overdose, when the EMTs come, the police come, you take a person to the hospital, then there's a team that reacts to that, all of that. $16,000 for one person when you call the EMTs. In the first 6 months of On Point being open, 500 people, 500 overdose in the site. And some people go, they overdose in the site. No, where do you want them to overdose? In the alley and die alone? That was the appropriate place for them to overdose. You know how many times they called the EMT? One time, 16,000. So now let me give you this out of 500, which means that what? 499 times, multiply that by 16,000, $16 million saved. When I heard that from Sam and his team, I was like, oh shit, forgive my language. But I'm like, oh, that's huge. The policymakers in New York said, no, this is something that we need to get behind because of that. Others, like me, we need to get behind it because it's the right thing to do. Our people are dying left and right. See, different language for different audiences. The drug courts have a different, right? And seek champions from within those organizations because that champion will take on the mantle and they will bring people along. I remember when the first chief of police said, we're not arresting ourselves out of this problem, we're taking people to treatment, and if we catch them with amounts of drugs, we're not processing them. This is in a small community here called Gloucester, Massachusetts. He's the first one in the country who said that, and law enforcement went sideways, accused him of being um, a social worker, soft on crime, all of that. That was 15 years ago. Fast forward to today, 44 states have visited Massachusetts. They're replicating versions of that program all over the country. How does that happen? I met him and I spoke to the chief and I said, what happened? What made you say that? And what made you stick to your guns in relationship to that? You know what he told me? He said, my relationship with the recovery community. I said, what does that mean, chief? He said, I had arrested these guys multiple times over my career. And then all of a sudden, I didn't see them anymore. And when I saw them in community settings at a supermarket, that sort of thing. And I asked them, how are you doing? You look good. What happened? He said, no, I got into treatment. I got into recovery. And so for him, a light bulb went off. He said, wow, I can continue arresting people, or I can join a different way, a different approach to doing this. And so there you have it, right? And that's true for any single institution, healthcare institution, legal institution, community-based organization, privately owned organization, faith-based. You have champions from within. In other words, we need to seek those out, create the partnerships there, grow them out from there.
Very cool. I just got the chills actually with that. That's awesome. The champion concept, I love that. Now moving forward, this is a little bit of a different question that might speak. Well, I'll ask and you speak to it. So John Rez, I believe that's how you pronounce it. John R asks, I always had a question. Why can many opioid users sustain their recovery without the use of medications or substitutes such as Suboxone or Vivitrol or other medications versus some people who can't follow or find recovery in that path?
Yeah, well, thank you for the question. It's not one thing because sometimes we're trying to pinpoint one thing. It's a number of different factors, right? And I always begin with recovery capital, internal recovery capital, external recovery capital. And it's very complicated. Now imagine for a moment that you have someone who's on medication and they're not able to um, abstain from using other substances, yet they're on medication and you go like, and then you have another person who's on the medication, doesn't use other substances. And so you want to compare them as apples to apples when it's apples to oranges, because when you one of those, the person who hasn't been able to sustain it, their recovery housing is not there. They haven't been able to get employment, co-occurring issue, a mental health condition, co-occurring issue, right? They might live with conditions that are stigmatizing. They might have PTSD. They might have trauma from the lived experience of being in prison for 5, 10, 15, 20 years from the ACEs becomes really important by ways of trauma. You right? There's no one thing that you can pinpoint. It's a combination of things, and that's why it's important to put out the multiple pathways. Right? When we go to a restaurant, what happens? They sit you down. They ask you, "Do you want something to drink?" And then they bring out this revolutionary thing called what? A menu. Right? They put it in front of us. They don't say you're having hot dogs whether you like it or not. They ask us what we want and we order. And when we like it, we have more of it and we tell other people. Or we eat somewhere else if we don't like it, or we order something different from the menu. And so, your question is a really good one because it speaks to who we are and how we should be doing it, right? Many people in our field go, if I did it, anybody can do it. And I go like, slow down. What is that? If I did it, anybody can do it. You don't know the conditions that people are living in, right? Drugs change, pathways in the brain. And it's really easy to say, oh yeah, substance use and it can impact anybody. And so, but anybody can get into recovery if they're really willing to do it. And if they have the willpower and if they really want to do it, they can do it because I did it and I went from prison to jail. I don't give that talk. They're like, no, no, no. I believe that everyone should have access to recovery supports, clinical, non-clinical, all of that. And then we wrap our hands around people to support them in those processes. And if one thing didn't work or two things didn't work, at the very least, you learn that that didn't work. Let's work with you so that you can choose other things that that can happen. And at the same time, while that is happening, if you're still using, employ all of the harm reduction strategies and techniques that we have, right? So I don't think that anyone can answer that question with certainty, right? As to the why, because there are many, many different things that are happening. I do know this though. People that you say, oh, that person's never going to do it. It's going to be difficult, right? This is internal voice, Hannah. I don't say that out loud, but I have thought it because I'm a human being. And then that person goes out and does it, and you go like, oh wow. And have you ever met the people conversely who you say, oh, this person's really good. They're going to get it within a month. They're going to be fine. And within a month, they're still using. Assumptions are really bad. We can't eliminate assumptions. We can suspend assumptions, and we can engage with people in a way that is humanizing. That's the best answer that I have to that really good question.
I loved the concept of the menu and being able to that was for what could be boiled down as either you look at it very simply or you look at it as extremely complex. I love the approach you had to that answer. And honestly, I think that all of us could sit here for the next couple of hours and listen to this conversation, but we are running towards the end of time. So I do want to thank you again, Dr. Hernandez, for helping us launch this series with such depth and such heart. And thank you all for being here as well. As we've heard today, recovery is not a one size fits all. It's shaped by personal experience, by culture, access, and community support. And as we continue this journey together, we invite you to reflect on how your work can honor and uplift these multiple pathways. So you'll be receiving a follow-up email shortly with the webinar recording, slides, and any additional resources. And please take a moment to complete the short feedback survey because we'd love your thoughts on how to improve our services in the future. And again, we'll see you in 2 weeks at the same time as we continue our foundations phase, guiding principles of recovery. But until then, thank you so much. Thank you, doctor, and I hope everyone takes care.
Thank you, Patrick, and to the rest of the team and to everybody who joined. Have a good rest of the week. Thank you very much. And let's move recovery forward.
Love it. Thank you, doctor.